can we as caregivers help with impulse control?
Okay, I'm gonna answer this one. if only one of us gets it, I'm gonna get this one. I could not inhibit my automatic reaction. No, but quite seriously, probably the best thing that you can do for many of the symptoms, the behavioral symptoms of HD, things like difficulties with impulse control, aggression, a lot of these things, the key is to set up an environment to help the person be successful. So if there's something that they're having a hard time staying away from, remove that thing. Figure out what things are distracting, like what might be more attractive, so you can offer that. Any number of those things. Some of my colleagues may have ideas about particular things to do, but the most important thing is to set up an environment where somebody can be successful, because saying yes is a lot easier than saying no.
So how do you know the difference between HD and the real person? And you guys, I mean, this is an important question. Like, what's I think what they're asking is like, is this, how do you tell the difference? Like, is this a symptom of HD, or is this now your personality? So,
You want me to do that one?
I don't have a philosopher, but as a caregiver, it was always hard to draw that line between which of these changes are because of the HD and what is going on. Being that we in our family, we didn't know that HD was coming on, and my husband, probably looking back on it, he probably became symptomatic within our first 2 years of being together. And I started questioning myself, wondering, am I such a bad judge of character, or is some sort of change going on? As his condition progressed, I needed to keep reminding myself that Rusty is in there. He is still the same person underneath. He just has this, impulsivity and difficulty following directions, or difficulty doing things. And that was on top of the person who he still was. And I think it's just a matter of, it's much easier for the caregiver to adjust their thought process than to expect the person with HD to change their thought process. So for me, it was, I can still see the man I married inside what's going on here. It just has impulsivity and these symptoms on top of it.
I just kind of balance her out in the HD part and kind of level it out. Trying to see the real her versus the aggression, the mean part of, her being. I kind of balance it out. And I'm always like, oh.
And the reality is, once we reach the point of symptom onset, this is the real person.
Yes.
And we love them
Sure.
with what they were at their base and with what they are experiencing with their symptoms now. And this is real. It's all real.
Yeah.
Yeah, and I love what you said, Patty, because like you said, for you, it's like, imagine how frustrating it is for them, right? Like, that's what I try to do with my husband too, all of his changes and his losses, and, was it HD or was it his depression that he could no longer be a police officer? Like, what was it? It doesn't matter. It's just now this is what your reality is. And we love them, and we stand by them through the reality changes, right?
Empathy. Okay, so when you're asking, okay, so this is, with Enroll HD related to, when you are asking the HD patient questions and they believe they can still do things that are truly difficult for them, do you want a nod from someone else, like the caregiver in the room? Are you looking to see if they know, or are you looking for, their answer, or are you looking for the correct answer, if there's a difference?
This is an important question, and there are, having looked at data, the Enroll study is an important study, and I actually encourage everybody to participate in this. It's a once-a-year visit. It's an assessment of motor, cognitive, behavioral function, one-time blood tests to compare things, because the disease is incredibly more complicated than we thought. I confess, as a naive person starting HD compared to what I was doing before, I said, oh, this is going to be easy. We have one gene. We're going to have, I've been doing this for 20 years now. We're going to really be able to do this. But the disease in this presentation varies from person to person so much. So an important question that the audience person is asking is about a scoring called total functional capacity, which it asks questions like, can you still work? Can you do lower level than what you did before? Can you do not anything at all? Can you do housework? Can you manage your finances and rating everything? And yes, the answer is the evaluator would like input from the family member and the caregiver, and is allowed to make the judgment on the score. And there's a place on the scoring to say whether there was a second, with the information was only from the patient or from the patient and the caregiver. And it's clear that there are often differences between those two scores.
Smart. Love that fair. Okay, this is about physical therapy. I've heard our HD loved ones should be in PT from early and all the way through different stages. I was recently asked by a physical therapist, why are you here? And when I answered maintenance for as long as possible, and they were told by the physical therapist, that's not what we do. This was at a VA, and it seems like all they do is an eval and say, he's good and strong. How do I get the importance across to them?
Go to the right physical therapist. And actually, that no joking aside, and we're very careful when we refer to physical and occupational and speech therapy from our clinic, is we try to find a clinic that has a neurologically trained physical therapist and all of the therapists. Because a lot of our outpatient therapy clinics are very orthopedic focused. They're going to be looking at general gait, general strength. They're not looking at coordination, balance as much. A lot of the things that the person with HD wouldn't need. Although in the rehab arena, there does have to be some ability to demonstrate progress. That's the laws that we live by, or the regulations that we live by to get the services covered. I think that an annual, what we call it, the fluff and buff, the annual visit back to the rehab services, just to make sure that you're keeping the skills that you had earned or you had accomplished before, or also looking at, is the device that we recommended for you a year ago, is it still appropriate? And, or is it time for you to move on to a different device? From an occupational therapy standpoint, are there some other modifications that we can make to the home environment that can make you safer? And all of those change from year to year.
Great. And also, I think, like, in my area, I don't live next to multidisciplinary care. And so I've helped educate the people around me who are willing to learn. And so for the in-home care that came from my brother, I would give them links with kind of a few little tidbits about HD that's specific to what it is they're coming in for. So we had a speech therapist come in, and I had found a video on YouTube, and I sent that to them. So any kind of resources that you can find, without obviously being condescending, because we aren't, but just trying to show them that, like, this is how your specific job helps my loved one has been useful, at least in our clinic. Okay, so next
question that has to do with OT and PT. What should we be looking for when looking for a clinician for OT or PT? that we can find the right one?
You can ask them, if they have dealt with Huntington's patients before, or if they're in touch with a neurologically trained physical therapist. A physical therapist isn't going to say, oh, no, I don't have that type of training, but, someone who has seen HD before, or is willing to seek out that guidance.
Is there any certain accreditation or anything that would let us know, okay, they have some kind of experience? So
There's
you're not
an
just going
NDT
off, oh, yeah, I can
certification,
do
but-
whatever.
yeah. As Dr. Casa said, HDSA did have, and I think still does have, the online physical therapy certification. So you do need to be a physical therapist to get onto this, but you can send them the link from HDSA to say, here is something that will kind of give you the above and beyond that's specific for Huntington's disease. And some of the physical therapists in my area have been really open to that.
I love that, and again, did not know that.
So there is that, and one other thing is that some larger hospitals have separate divisions in PT. Our hospital, we have in board, when we, I, as a neurologist, with the consult, I can do 4 of those, unless I don't, or neuro PT in different categories. So larger hospitals may have a more subspecialized physical training and then OT program.
I know it's supposed to be one person, but just make sure also that people that whoever's making the order is not just putting in range of motion or evaluation, but change of status, kind of like what Patty said. There has to be either a change or that there is going to be a progression. If you get in physical therapy or occupational therapy, we're hoping to get the person back to more independent or a baseline if possible, which is hard for people with HD. But if the person who's putting the order in will say that there's a change in status, there's issues with balance, there's issues with swallowing, whatever it is, increasing falls. Anytime that there's going to be a change in status, that will trigger the insurance as well to give you another couple of sessions.
How could neurologists become more educated about HD? Are there neurologist conferences where HD can be talked about?
Yes.
Next question.
For instance, this year in April, several of my colleagues offered a course at the annual meeting for all neurologists so that they can attend. Whereas the HSG has the training programs for neurologists. You don't have to have any experience. You can sign up and get credit for training. So there's actually a number of sites and places where in-person or online training for neurologists in HD.
And when you think outside of the box, this is not just a movement disorder. So as in my clinic, it is run by us in psychiatry. So think also, not to put down any neurologists, I know a lot of them in the room here, but it is also a disease that can be, if you think about who runs the program. So is this run by a social worker, is it run by psychiatrists, is it run by neurologists? These are all the different people who are educated. And I think that that's important just to remember.
And it's across the country. This is a multifactorial disease. We used to call it Huntington's chorea. We stress now. It's not just chorea, it's other movements, it's cognitive, it's psychiatry, and across the country, HD centers are in different clinics. Some are in psychiatry, some are in cognitive behavioral dementia programs, some are in movement disorders, some are in psychiatry. I'll miss some.
Is apathy a significant symptom of HD? Why? How can it be dealt with most successfully?
Apathy is really tough. Yes, it's significant. Let's see, why is it? Oh, because the things that affect motivation and our sort of our get up and go are in the frontal part of the brain, and HD predominantly affects how the front of the brain works. Okay, so it's going to be, and it's closely related to that disinhibition, impulsivity kind of stuff, which is strange because it seems like it's completely the opposite thing. How to deal with it? It's really tough. It's another one of these things where often setting up an environment for people to succeed is going to be the best intervention that we have. So often somebody who has apathy, if you go up to them and say, do you want to take a shower. They will say no, I'm fine. But if you go up to them and say, hey, it's time to take a shower, they may actually be much more willing to participate in that. So what I will often tell families and caregivers is your loved one, there are certain parts of the front of their brain that aren't working as well right now. So you have to be that part of their brain. You have to act as their motivation. Unfortunately, it's not as simple as that, but usually what it is having people help them and guide them through doing things, as opposed to counting on people for having their own internal motivations.
Having a set schedule is also very helpful.
Set schedule.
Set schedule, very helpful.
Environmental enrichment is slow disease, helps the disease. You want to encourage people to do as many activities. I like to my patients, if she goes, go to the kids' soccer game. If your wife wants to go, out, go out. But it is one, it's a finding that's not measured well, but it is probably the most common behavioral change we see first in people.
And I'll say one thing is it often gets confused with depression. And the medications that work for depression aren't really going to help apathy. That said, if you're worried about somebody being either depressed or having apathy, starting a medication for depression can tease out the difference between those two and may make things better, because if the person is depressed, it will help and it will relieve some of what looks like the apathy.
One more story, I know we're running out of time.
We're doing okay. We're doing okay.
So I had a woman who I've been following, and she'd been having lots of problems. She couldn't work, she couldn't pay her bills, she was getting in debt. And finally, the mother said, just move back home. So she moved home, she comes to visit. I thought she was doing great, right? So I didn't change her medicine. She was calm, she was contented. And her mother kept calling me after every visit saying, why aren't you treating her depression? And we do extensive depression and suicide screens on every patient that comes to clinic. And I said, she's not depressed here. She's content. She has no bills to worry about. She has her meals there. And then that really struck me how, even myself, I haven't stopped to think how much people think depression is apathy. It's not necessarily. I explained it to her mother. She was content sitting watching TV. I encouraged her to have her go out on walks with them, but it wasn't depression.
We'll just jump in and say, every single time when I have a patient come into the clinic, I will say in front of the caregiver, on a scale of 0 to 10 in terms of your suffering, where 0 is no suffering and 10 could be the most that you're suffering, where would you put yourself? And a lot of times people will say a 2 or a 3, and the caregiver will go, like, what? I would have said a 12. So it is about perception in terms of, is that person comfortable just sitting on a couch? And I know that that's not what you want them to do. The other part in terms of being a caregiver, we gave you really good suggestions in terms of enriching the environment, asking them, is think about that fine line between nagging them all the time and your frustration as a caregiver versus encouraging them. So give them a couple of times we say, hey, we're going to go out. It would be great for you to come with us. But if you're in a situation where you're nagging them all the time, you're going to be frustrated as a caregiver and they're going to be frustrated and they're not going to be changing their behavior. So figure out that fine line, and you might have to dial it back just a little bit so that both of you are not frustrated.
Save the nagging for the things that really count.
Yes. Yeah. Okay, any recommendations for what to do when antipsychotics seem to stop working? Currently on the highest dose of haloperidol and quelapine. Thanks. But still have breakthrough hallucinations. And then second part to that is any meds that can help him or give him more energy that will not interfere with the above medications.
Okay, number one, there is no highest dose of haloperidol.
That might not be the right one. I'm gonna try to bring it to you. So it starts with the Q. Is that?
Quetiapine
Yes,
is the other.
yes,
Yeah.
okay.
Often quetiapine isn't very helpful for hallucinations. That's another thing. I think you might need a psychiatrist who specializes in HD, which is probably not very helpful information, but it's really hard to give specific medical advice without being able to do a full exam. But I would probably get a second opinion.